today for the South Texas Regional Family Medicine Grand Rounds. Our educational partner, the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Andrew, mind clicking in on it? All right. Thank you in advance for being the presenter and being engaged in the session. For our virtual guests, we appreciate you muting your microphone once the presentation begins and keeping your cameras on when appropriate. Thank you also in advance for registering for each CME credit for each session and for completing and submitting a session evaluation form. So today's film code is 1093217. You can register your attendance and claim credit via the CME credit via text system. If you have not registered, text your email address to the number on the screen, 844-502-1338. And the next attend 0093217, and you must register for each session by midnight. Here's some information about. All right, you can access your CME instructions on the screen. For AFP members, you can use your AFP login and claim credit for the activity at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 credit by the AFP. Physicians should claim the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds address nationally established physician core competencies, the following nationally physician core competencies: the Institute of Medicine competencies, the ABMS ACGME competencies, and AAMC competencies. Society of Family Medicine, University of San Francisco. The relevant financial partnerships noted for Dr. Lynn have been created. Additionally, Dr. Lynn is the James Puffer American Family Medicine Fellow at the National Academy of Medicine, and the opinions expressed here are solely his own and do not represent the views or opinions of the National Academies. So, Dr. Nita, if you don't mind presenting it.
Thank you. It's an honor for me to family medicine from University School of Medicine and completed his training at Stanford's Family Medicine Residency Program. Dr. Lynn is an active member of the American Board of Family Medicine and the Society of Teachers of Family Medicine. He has received numerous national awards and is the James Puffer ABFM Fellow with the National Academy of Medicine. Dr. Lynn is the Section Chief of General Primary Care and the Vice Chief of Technology Innovation for the Division of Primary Care and Population Health at Stanford. He's a founder of 3 nationally recognized programs: the O'Connor Stanford Leaders in Education Residency Programs, the Stanford Medical Scribe Fellowship, and the Stanford Healthcare AI Applied Research Team. He is the author of 400 scholarly works and conference presentations. His research covers a broad range of topics with a focus on artificial intelligence and machine learning in medicine. In 2019, he founded the Stanford Healthcare AI Applied Research Team with a mission to translate leading edge artificial intelligence technologies from code to bed, and in support of the quintuple aim. His team has collaborated with over 40 centers across the industry, academia, nonprofit, and government. Their work has been featured in the New England Journal of Medicine, by the National Academy of Medicine, at technology conferences, and on national public radio, and in over 100 news articles and interviews. So, give you Dr. Lynn.
Thank you so much. I'm realizing that I may be wearing exactly what that photo was showing. Not of course intentional, but thank you all so much for having me. And I want to thank the organizers of Primary Care Week for inviting me all the way out from sunny California to San Antonio. I was just talking to Dr. Shi yesterday, trying to remember when the last time I was here. And I think it was a very long time ago at a STFM conference. I was a med student here. And I distinctly remember sort of the conference was by the Riverwalk, like walking down the Riverwalk, thinking how beautiful it was, and then having like the most delicious flan I've ever had. And then I went back and told everybody about the flan. People thought I was crazy. So that was a really good memory for me. And now I'm back. Thank you for having me. I usually like to start by answering sort of the most common question that I get at conferences and talks, which is, how did you end up doing what you're doing now in AI? And sometimes my response surprises people. So the first thing I say is that I have zero computer science background whatsoever. Never taken a course in data science. I somehow got through my training without ever taking a course in statistics, never coded anything in my life. I also tell people that I actually have no formal research training. I'm just a guy who likes to share and write about the stuff that I do. I was never formally trained as a researcher, and I don't think of myself as a researcher. What I am is a frontline panel-carrying family physician that still sees patients weekly. I'm a little bit of a nerd when it comes to clinical operations and quality improvement. That's my jam. And while the reason I got into all of this was many, many years ago, I was the medical director of our main faculty practice at Stanford. And the year that I assumed directorship, half of my faculty quit because they were burnt out. I was devastated. And I was trying to find ways to hire more people and to prevent further burnout. And they were burnt out because of the usual things, documentation burden, having to write all of those notes during pajama time at home. It was then that I got a phone call. It was from Google. And Google wanted to do something in AI. And I was like, what? What are you talking about? It turned out that Google had heard about a human scribe program that I developed using post-baccalaureate medical, pre-medical students as medical scribes for our clinics. And they wanted to develop a digital version of a human scribe. So an ambient AI device that can listen in on patient and physician conversations and automatically generate a note for you. I said, sign me up. I don't know what AI is, but if it helps prevent burnout and more faculty quitting on me, I'm all in. And that was the beginning of that journey. After that project, which was really, really fun and successful, I started to explore what other applications of AI might be with that lens of a clinical operations leader and a frontline physician. And I did a landscape analysis for many groups at Stanford that are doing healthcare AI, groups around the country that are doing healthcare AI. I created a team to do healthcare AI in a unique way. That's uniquely us, focusing on what we cared about. And I identified 3 problems that I knew I wanted to tackle. The first problem was that there was not nearly enough attention to primary care in the AI ML space. Radiology, 20% are oncology, 8% neurology, and only 3% of FDA tools are intended for primary care, and less than 1% of all AI/ML research funding goes to primary care. This despite the fact that everybody in the room knows primary care is responsible for 52% of all care delivered in the US, more than all other specialties combined. So there's a mismatch there. And one of the things that I really wanted to focus on was to spread the gospel of primary care to technology developers that don't understand what primary care is and how important it is. The second gap was a lack of focus on implementation. So what I saw was remarkable work being done in the data science space, where our data scientists were building increasingly sophisticated models that could do X, Y, and Z, but almost no attention was being paid on how those tools would actually be integrated into the complex human-driven processes of clinical care. Healthcare is very, very complicated. And to think that you could just build a tool that could plug right in is pretty naive. And that's probably why 90% of AI ML models to production. And even those that do, 97% of FDA-approved AI ML tools never undergo prospective evaluation because they cannot be in existence of care. So we needed a different body of literature around the implementation side of AI, is very much in its nascent stages. And then lastly, I think there's still not enough attention to diversity, equity, and inclusion issues in AI. Sure, in the last few years, I think there's been a little bit more attention paid to the concept of coded bias. I want to think a little bit broader than that. I think about inclusion. Are we asking patients? Are we asking providers what their experiences with AI are? How about bridging that trust gap in AI? All of those things are not things that are currently being studied broadly. And one thing I'm really aware of is that AI ML activity is heavily concentrated in the very short list of affluent academic medical centers, and community engagement is little to non-existent. So can we do research that actually advances equity by engaging people who have not been able to participate in the conversation so far? So I thought about these three pillars, and I decided to create a research team, that is the Stanford Healthcare Applied Research Team, by focusing on three strategies against these pillars. One is we're going to be aggressively collaborative across sectors. That means engaging directly with industry. This is not something that other AI/ML centers do at Stanford. We want to make sure that the Googles, Microsofts, and Amazons out there understand primary care and what our issues are. We believe that that's the only way we can actually move the needle, right? And not just by doing research in our own little silos. For implementation, it's about the folks that I'm choosing to include in the team. And so focusing on the implementation science side of AI/ML. So my team is very unusual. We have no data science expertise at all on our team. Nobody can code. There's no data scientists at all. We don't build anything. We work with people that do, and we provide that implementation science expertise downstream. So we are completely composed of primary care physicians, nurses, pharmacists, frontline healthcare workers, implementation scientists, veteran healthcare improvement experts, both in the inpatient and also in the ambulatory care settings, and learners, because they know exactly what's going well and what's not going well in the clinics. And then from a diversity, equity, inclusion issues, we know we really needed a partner in the policy-making aspect of AI and ML. And I'll describe a little bit of what we do later. So this is my wonderful team. I'm so blessed that I get to work with them every single day. And I love giving these talks because it gives me an opportunity to brag about their work. They're so humble about it. They are PCPs, again, research assistants coming from the social science space. And we usually have a couple of residents, fellows that work with us. This year, we have 2 clinical informaticists, one of them doing a VA advanced research fellowship with us. And this is a snapshot of our current portfolio at heart. I show this because I wanted to sort of demonstrate how we thought about our projects by grouping them into 6 different categories. One is clinical decision-making, one-to-one bedside clinical decision support for clinicians and patients. The second is population health management, looking at an entire cohort of patients and thinking about how to close care gaps and improve quality. Value-based care, clinical intelligence tools that allow us to decrease total cost of care or predict unnecessary utilization. Transitions of care, tools that are specifically used when there is an escalation of care that's needed or a transition between healthcare settings. Care team burnout. This is why I got into this space in the first place. So thinking about clinical documentation burden reduction, prior authorizations, messages from patients to the patient portal. And then this last one on health policy, education, and development, focusing on how can we advance issues of equity, education, and research capacity building on a national level. So in the next 30 minutes or so, I'm going to highlight not all, but a couple of these projects so that I can give you a taste of the stuff that we do. And I'd like you to, as we go through the projects, think about the 3 pillars that I talked about before: being aggressively collaborative across sectors, focusing on implementation, and then focusing on engagement, getting inclusive perspectives, and thinking about policy and capacity building. And hopefully those themes are going to resonate throughout these projects. So diving right in, clinical decision-making. The first project I want to highlight is one with Google. So after that digital scribe project that I talked about, got another call from Google. This time they said, hey, let's do another AI project together. We have this tool called Dermassist. It's a deep learning neural network that can take photos of skin lesions and generate a differential diagnosis. Can you refer us to a dermatology colleague at Stanford that we can work with? So I said, did you know that primary care providers actually see the vast majority of skin cases globally? And that if you put these tools in the hands of PCPs, especially in rural settings or certain global settings where access to dermatology is little to non-existent, you can really do a lot of good. They said, oh, that's very interesting. So let's work together. So this is what we have. We have a smartphone app. We can take photos of skin lesions, generates a differential diagnosis and management recommendations. We want to see how PCPs and we want to see how everyday users, patients respond to this work. We built this out of 16,000 cases. It can detect over 400 skin conditions. We've retrospectively validated it's non-inferior to dermatologist diagnosis and superior to PCP diagnosis. We did a prospective study in a telemedicine setting, and we were able to show that it improved PCP diagnosis in 1 in every 8 to 10 cases. But here's our problem. We don't know how an everyday user is going to respond to this from a patient perspective, because so far we've only tested it on Googlers. Second, we have no idea how a PCP with this tool might react and use this tool because we haven't tested it yet. Want to do this at Stanford. Oh, and by the way, we want to get a diverse perspective, diverse patients and diverse providers. Said, yeah, that sounds great, but the problem is that Stanford's not very diverse. So if you want to do this work, why don't we do this in the community? So what we did is we set up a collaboration with the Santa Clara Family Health Plan, which is a health plan that serves a series of FQHCs in our county, predominantly the lower resource underserved parts of the Bay Area. And we participated in a series of skin health fairs that the Santa Clara Family Health Plan put together. We invited PCPs and dermatologists to do a traditional skin health screening with community health participants. But here's the twist. When they come in for their screenings, before they saw the provider for their consultation, they got to use the tool on themselves. Our scientists and the Google qualitative scientists were there to see how they use the tool, help them troubleshoot if necessary, take notes about how the user interface might be working and might not be working, answering questions with language support. And then they took the tool with the differential diagnosis that it's generated and go see the clinician, either a primary care provider or a dermatologist, who does their separate evaluation and then have a discussion with that tool's diagnosis and output as a consideration as well. We learned a lot, and over 4 different health fairs, we talked to over 100 diverse community participants. We found that the participants were very satisfied in general with the app, and Dave gave a lot of great recommendations to the Google team. One very easy thing was, hey, you need to translate this into multiple languages, something that was actually not on the roadmap for this particular team. And because of that, we were able to translate the tool into 6 different languages, including Spanish and Vietnamese, which was our target population in that community. And the clinicians were also really impressed with the tool. 86% of the time, they thought that the tool's output was concordant with their own assessments. And they were able to give us a lot of rich, nuanced feedback about how they would actually interact with such a tool in their own clinical practice. So it was a really successful event. And our hypothesis is that this type of study, which really combines traditional academic research with product development, with meaningful community service, might be a good model to bridge the gap between industry, community, and academia in future works around AI and ML. Moving on, second example is around population health management, and this one's on remote patient monitoring. So in the last couple of years, many companies, digital health platforms have sprung up around chronic disease management, obesity, diabetes, hypertension. They use connected devices like blood pressure cuffs, scales, glucometers that can collect a huge amount of data. The AI on the back end synthesizes and interprets that data and then sends it to a diabetes nurse educator that can provide targeted health coaching to patients. In theory, this is a fantastic way to extend, our ability to provide chronic disease management in the virtual space. In practice, all of these companies, almost all of them, exist completely outside of the healthcare system as their own independent entity. And when a patient of theirs needs an escalation, they toss it blindly over a wall and hope it lands somewhere. Most of the time, they don't have a PCP. Well, that's too bad. Even if they have a PCP, how do you access that data? You can't. And so we really wanted to know, A, do these platforms actually work? Because there's no RCT data on whether or not they're effective. And also B, can we actually meaningfully integrate with these types of services rather than participating in parallel next to each other and never talking to each other? So we interviewed a whole bunch of these companies, the top 3 industry leaders, and we decided that we were going to work with Omada Health, which is one of these virtual tech companies. And we set it up in a very interesting way. It is a traditional RCT in some sense, which is looking at our hypertensive patients, Omada versus Omada plus usual care. But we did it in a way that was sort of like a hybrid research implementation study, where we did all of our recruitment that's integrated into our population health outreach. So when the patients get that email from our population health nurses asking them about their blood pressure, they're also given the opportunity to enroll in the trial. So it was one message across one team, not a separate research team and then a clinical operations team. The entire enrollment process is completely remote, and the trial was remote. We mailed patients a little box with their scales and the blood pressure cuffs and all of the instructions that they need in order to enroll in the trial. They did all their baseline measurements doing that, got onto the program. Same thing with the endpoint measurements as well. And then this was the first time that Stanford School of Medicine, Stanford Hospital Systems, and an industry partner, Omada, jointly funded an RCT in this way. So it was a very unique collaboration. This trial is still ongoing, but so far we've reached out to more than 11,000 patients. We collected over 1,500 blood pressure readings. And so even if they're not part of the trial, we're getting those blood pressure numbers for our HEDIS quality metrics. And then we've so far enrolled 250 patients in a fully remote fashion, and we're about halfway through the study so far. The coolest thing about doing this trial isn't necessarily whether or not the RCT is going to be successful, in my opinion. It's about building those integrations already. So we've solved the EPIC data issue through an integration with Zelfs, so that the Omada data can actually flow freely into our EHR now. So if one day Stanford decides to integrate with Omada, we can turn it on and be fully integrated overnight. All right, third example is around value-based care. So we get a lot of calls from startup companies all the time. And one of the things that annoy me the most is that they usually come to us with a product that they think solves a problem, but it really doesn't solve a problem at all. Usually it's like the data science team has access to a data set, they built a cool model out of it, and then they come to us and say, what can we use this for? Is this actually useful? And most of the time we say, sorry, it's not actually useful. But there's a startup company called Codex that was based in Palo Alto a couple of years ago that approached our team. And they approach it in a very different way. They actually asked us, what are your problems? What is a problem that you want to solve right now at Stanford? Which caught us off guard, but we took advantage of that opportunity and told them all sorts of things. At that time, what the institution was really focused on was a transition to value-based care. Stanford had created its own ACO-style health plan called the Stanford Healthcare Alliance. That's a risk-bearing arrangement. And they were also starting a Medicare Advantage plan that was a risk-bearing arrangement. So we needed tools to help us do value-based care. So what we did was we collaborated with this company to assess the current state, which is really this. A patient goes to the ED or hospital, a claim is processed, the health plan will flag a preventable visit or super utilizer, send it back to us, and there may or may not be an intervention. And our desired future state was really this. What if you can use an AI/ML model that was running on real-time EHR data, that was predicting the risk of ED visits or hospitalizations, using all of those data elements in that green box there, that is synthesized and sent to the PCP and the team to provide human input and oversight. And then you have continuous interventions. And in this case, the claims augment the model, not dependent on it. And so it's really prospective and predictive rather than retrospective and relying on claims. So we took 7 years of data from our Stanford primary care population, about 70,000 impaneled patients. And we built 6 models, one that could predict all-cause ED visits and hospitalizations, and then 5 others that are focused on ambulatory care-sensitive conditions like hypertension, CHF, COPD. And they worked very, very well. And we created a platform that allowed us to visualize aggregate risk, that allowed us to identify patients with care gaps, as well as rising risk. So we can reach out to these patients that are not engaged with the system and getting riskier and riskier for preventable utilization. And then use the tools to take a look at our utilization and close guideline-directed medical therapy care gaps that were outside of the traditional HEDIS metrics. So right now we're using this tool to try to reduce total cost of care and see if we can use it to empower our VBC efforts. Transitions of care. So the story here is that several years ago, a brilliant data scientist, Nigam Shah, who's actually Stanford's now chief data science officer, built a model that could very accurately predict the risk of a patient passing away in the next 12 months. But he didn't know what to do with that model. Right? So their data science team, they're on implementation team, and they reached out to us and said, hey, can you think about a way for us to implement such a thing? After many, many conversations with our house staff, inpatient medicine service, palliative care, social work, case management, we decided that we would use that kind of tool as a proxy for prioritizing advanced care planning discussions with the goal of making sure we have more documented ACP conversations for those who are at highest risk of dying. So we implemented this on the inpatient service for over 11,000 patients. The AI flagged patients that were in the top 25th percentile predicted 12-month mortality. About 2,500, 2,600 patients were flagged by the AI as candidates for the ACP as part of this endeavor, which is about actually 22% of all the encounters. And what happened was if the patient was flagged, the EHR would send a recommendation to document that advanced care planning discussion. It would send the house staff team that was taking care of the patients a copy of the serious illness conversation guide, which they all received training on in order to facilitate those discussions. And there was an automatic social work case management and a palliative care consult to support the team to have those documented ACP conversations. And if the conversations were not completed during the inpatient stay, they would be handed off to the primary care provider to complete that discussion once they were out of the hospital. So we published this in the New England Journal Catalyst, along with another algorithm that predicted the risk of ICU escalations and rapid responses. And I was really thrilled to be part of an interview on NPR about this, which focused on the ethics of these types of predictive models, which is really interesting. So as a patient, would you want to know that an AI ran your numbers and calculated your risk of dying in the next 12 months? Should we tell them? it was a really interesting discussion that has no right or wrong answer, in my opinion, but a complicated one. Care team burnout. So I don't know if patient messages are a problem at UT Health San Antonio, but at Stanford, it certainly is. Let me give you a sense of the scope. So at Stanford, we don't have a particularly large primary care ambulatory footprint. We have 12 clinics, about 150 CEs, 70,000 in-panel patients, but every single day, we get 5,000 patient messages in our in-basket that we have to go through. Completely existing in unstructured clinical text that some poor soul, usually a non-clinician, has to read all the way through, figuring out what task is needed to resolve that message. It's a bottleneck in the process, super labor intensive, and delays and impacts patient safety. And then really the challenge is getting the right message to the right person faster. We worked with a startup company out of New York called Quadrant Health, and we shared with them 2 million messages that happened at Stanford. And we built a custom large language model that can help categorize these messages. At the same time, we did a landscape analysis. We went into 6 different ambulatory care clinics from primary care to cardiology to neurology to figure out what were the common work types across all clinics, across different specialties. We landed on these work types: medication, scheduling, paperwork, etc. We also developed a separate category that was about a clinical urgency. So whether or not somebody needs to look at this message right away, a clinician, or is it not so urgent and can wait for the pool? We then tested this by labeling 1,500 of those messages manually using providers, and we compared it to what we currently have, which is patient self-categorization of messages. So right now, when patients send a message, they can actually select why they're sending a message. It turns out that patients are really bad at categorizing the messages that they send. And sometimes it's not their fault. Like a lot of these messages are actually multi-dimensional messages that don't fit into one category. A perfect example is, hey doc, I have crushing substernal chest pain. Can I get an appointment with you? What kind of message is that? Is that an appointment message? That the patient categorized it as an appointment, but what it really is a high acuity triage question, isn't it? And so we did this, and it turns out that the AI is far superior in categorizing the messages, multi-labeling the messages than the patients are able to do on their own, with very, very good accuracy, sensitivity, and specificity. So it shows that using AI to categorize messages is actually able to achieve a level of accuracy that enables the automation of routing. So now we're trying to figure out how we can use that tool to help with our messages. But once you route the messages and the appropriate clinical question still lands in your in-basket, you still have to deal with it, right? You still have to reply to it. So here's a second message-related project that we did. And of course, ChatGPT is on everybody's minds, since they sort of burst onto the scene a year ago. So this was a collaboration with OpenAI and Epic. And the idea was to create a large language model driven auto reply draft tool that can read a patient's message, take a look at their medical records, draft an appropriate response for the physician to edit, and then send back to the patient. So this is an example. Patient wrote, when should I get a COVID-19 booster shot? I just got my first vaccine dose yesterday. And here's an example of that GPT-generated auto reply. Now, as a clinician, you could click with Start with Draft and use this as a draft and then edit it and send it back. Or you can start a blank reply, scrapping the whole thing and then typing in your own response. We also did it in a way that you can, as a participating clinician, tell us whether or not this was helpful or this was not helpful. And then once you click helpful or not helpful, give us a little bit more nuanced information about why or why not. So we rolled this out to over 200 providers in both our primary care and also our gastroenterology digestive health divisions. MDs, APPs, RNs, clinical pharmacists. And this is hot off the press. We're still analyzing the data, but we analyzed the data on 80 paired providers for whom we have both the pre and post test. And the top line here is that there were statistically significant reductions in perceived mental workload, as well as burnout symptoms in a validated instrument just within the month that we rolled out the tool. Interestingly, the time savings, we did not see a statistical change there, probably because a lot of the clinicians using this for the first time are reviewing it very, very carefully before sending an AI out, which is really, really good. What we found was that most of the physicians didn't send out the AI response verbatim. They edited it a little bit, which is really helpful as we got to understand what the AI was really good at and what it wasn't good at. For example, in response to sort of general medical questions that you can do a search for online, the AI was really, really good at that. And most of the time, it only required minor, if no edits at all. But more of the high complexity, highly nuanced, psychosocially sort of charged messages, the AI doesn't really do a good job on those. So as we would expect. So right now, we're really analyzing this data, plotting our next pilot, and then hopefully being able to roll out more broadly at Stanford. Lastly, I just want to talk a little bit about some of our health policy, education, and development work. So in terms of rules and regulations around AI, as many of you probably know, it's kind of the Wild West right now. And so we're really fortunate to work with the National Academy of Medicine on a couple of different projects that hopefully will make an impact in that space. One was the development of this consensus study report toward equitable innovation in health and medicine that was released just about a month ago. And in this, we developed a framework for an equity-centered technology governance framework that considers every part of the innovation lifecycle and all of the ways in which equity can be threatened, and all of the ways in which we can use both soft and hard governance levers to promote equity across sectors. So we make recommendations in this report to academia, to industry, to government, about what we can do in order to advance the ultimate outcome of equitable innovation ecosystem. The second project is this concept of an healthcare artificial intelligence code of conduct. So there's actually an epidemic of codes of conduct of AI, if you can imagine that. This beautifully crazy and scary graph represents all of the different codes of conduct that have been produced, but most of these are produced within single sectors by specific interest groups, focusing on a segment of AI that they see. What we're trying to do right now is to see if we can create a foundational code of conduct that would guide the development of AI in biomedical science as well as health and healthcare. So this is a 3-year project that really is convening leaders across health, tech, research, and ethics to create this foundational code of conduct. You might recognize some names and faces here. We're trying to include leaders from Microsoft, from Google, from Optum, from United, from Intermountain, from Hopkins, across sectors in order to help us develop that foundational code of conduct. And we're really honored to be a part of that first paper that will be coming out hopefully in a couple of months. And lastly, and I'm really excited about this, research capacity building. So we love to talk about what we do, and even more excited in order to sort of get together other fellow departments of family medicine that are doing cool, interesting things so we can learn about them together and disseminate those best practices. So last year, the American Board of Family Medicine started a grant program that embedded AI/ML scientists within departments of family medicine. And we're really fortunate to be able to lead this national collaborative in a learning collaborative model. As you can see, UT Health San Antonio is part of this. Dr. Yun Shi and the leaders here at the Family Medicine Department are part of this project, as with University of Houston, University of Pittsburgh, UCSD. And really, this is about advancing a shared vision of strengthening primary care with AI/ML technologies built by primary care for primary care. Members of this group have done things like create competencies for the use of AI in primary care, both at the UME, GME, and also the CME level. Talk about changes that need to happen with the human and IT infrastructure in this country in order to accelerate research opportunities in AI and non-primary care. And we're all very passionate about thinking about how primary care is probably the most well-situated specialty to lead healthcare AI, and why we must be at the table in order to develop technologies that will ultimately help us rather than harm us. I'll put in a plug here for a AI and ML bootcamp, a pre-conference workshop that we're holding at this year's NABCRG on October 30th. We have a really exciting day planned out with lots of great speakers in the morning, and then an afternoon research pitch showcase where all 4 of our collaborative leaders are going to be part of a panel that will be reacting to 3 primary care AML research pitches by our GGP fellows. That's the grant generating project fellows that are part of the NABCRG grant funding project. So this was really going to be great. This is free, open to all. As of yesterday, we had 120 participants sign up already, and hopefully able to accommodate more. So in summary, those are some of the projects that we're doing right now at Stanford, and I hope that you can see these 3 pillars highlighted throughout, how we're able to develop effective cross-sectoral collaborations, how we are focused on the implementation side of AI/ML, and how we partner with AI/ML policy leaders doing health equity work and engaging in the community across these 6 different categories of work. So I'll end by saying that's how our research team sort of approaches AI/ML work. I'm going to step back a little bit and think about how can primary care organizations advance AI and ML? And I have a couple of ideas in this space. One is, I think it would be a good idea to really demystify AI by focusing on use cases that matter to primary care providers and systems. When I talk about AI/ML across the country, there's often a huge spectrum of ideas about what AI actually is and what can it do. But where you really gain trust and connect with frontline primary care providers is when you talk about AIs that can make their work lives a lot easier, right? When you talk about AI that can reduce the administrative burden, help with charts, help with their patient messages, help with prior authorizations. To me, that kind of administrative burden reduction technology use case is one of the lowest risk but highest benefit AI use cases that we can focus on right now. It's a great place to start if we want to build trust and then move on to perhaps riskier and more ethically nuanced applications of AI. The second is really the opportunity to rebrand primary care as a go-to specialty for trainees who are interested in AI. 10 years ago, when I started out as faculty, the way you got students to really go into family medicine was talking about procedures, like holding procedure workshops, knee injections, suturing, all of that stuff. Even at Stanford, where 1 or 2 people go into family medicine every year, that's how we did it. That's how we got them excited about it. Nowadays, I see the same type of excitement when I talk about AI and when I talk about family medicine and AI. And medical students can see that. Oh, I get it. You guys are the closest to patients and communities. I get it. You guys are the foundation of the healthcare system. You're interconnected to every part of the healthcare system. You are the best situated to do AI. I get it. And I think it's an opportunity for us to use AI and rebrand primary care as a desirable specialty for trainees. And then lastly, and this is my dream, I hope that we can get the family of primary care organizations together to craft and advance a unified AI vision. And this is what I mean by that. We have organizations, both on the family medicine side of the fence and also internal medicine, that work on workforce and advocacy issues. They can help us think about how AI can help our current workforce needs and the policies that need to be in place to empower an AI-powered workforce of the future. We have organizations that are focused on education and training, thinking about how to incorporate new competencies for AI/ML into UME, GME, and CME. And then we have organizations that are really interested in research and data. And how can we support a new generation of primary care researchers that are really interested in advanced AI/ML for the good of primary care? And if we can all come together, I think this would be a powerful national primary care AI strategy that could make primary care a really great place to work. And I'll stop there and I'll see if you have any questions. Can you clarify what you mean by? Yeah.
How the data is owned by health systems, by how we about expanding or scope research.
Got it. So for those who are on Zoom, the question is about sort of issues around access to data in order to do the type of AI/ML research that we want to do. It's a tricky one. You know, hospitals and health systems are really protective of data and really don't want data to flow outside of their walls. There are not a lot, but some powerful primary care centered data sets like the American Family Cohort that can be leveraged to do interesting research. And this is part of what I was talking about institutions like ABFM really helping advance the capacity building and the research infrastructure around what we can do with those types of cohorts. The other thing that I think about Awesome. The other thing that I think is very promising is this idea of federated learning, where, you know, instead of data moving out of health systems, instead of data moving out of health systems, you move the model, not the data. So you create the model, you send it to health systems, you train it on their data, and then the models go back to a central place and recombine to form a better global model. I think that's pretty promising as a way to fix some of the, or to get around some of the data sharing privacy issues that we have around health systems today. Yes.
So I guess it's specifically like messaging is part of the AI utilization, but when I think of that, it's mostly like, I mean, you call any business nowadays, you know, it's going to be like, you know, what's the problem? I mean, directly, kind of step in the loop of what they consider the proper gratification, like, I guess, connection to, right? Personnel, but then you have to be transferred, and all that stuff, and kind of get lost in like whatever system they have implemented. Right, kind of give that. But I guess in healthcare, they have been less their concern. What's preventative measures like prevent them from getting lost in like improper like strategy? You know, like is there a human like kind of like sorting through those patient messages still, or are they gonna get redirected to pharmacy every time they fit in like a few words kind of like send that out later? And then
Yeah, I really appreciate that question. So to clarify, the AI categorization work right now, we think that there's a lot of promise in terms of the accuracy of the model to automate the routing, but we're not doing that right now, right? So we're still using a human to route the messages, but we're tagging the messages with those labels to decrease the cognitive burden of the human being that's routing those messages and sending them the right way, so they can match the labels to standardized workflows and standard operating procedures to make sure that they're getting to the right places. So there's always a human in the loop current state. The other way that I would respond to that question is, what is the current state of messages today, right? I was walking from internal medicine grand rounds to one of my other sessions this morning. I was talking to the division manager of general internal medicine. She sent her PCP a message in July. It hasn't been responded yet. What's the current state? And so the current state is a mess. If there's anything we can do to make the current state even a little bit better, I think it's worth exploring, especially if we do it in the right way with a human in the loop, making sure that we're checking to make sure that the labels are categorized correctly. Also, the system that we're going to put into place allows some learning and continuous improvement. So if you see that the message is incorrectly labeled, you can suggest the correct labels as a physician, send it back, and then that really helps the model fine-tune itself and get better over time. So we're hoping that it's part of the solution. It's not going to be a cure-all, but if the right messages can get to the right people faster, there's a chance that we can avoid that 4,999th message being, I'm really depressed, I want to jump off the Golden Gate Bridge. You finding that out at 4:59 p.m., right? Yeah. Yes.
Have you encountered any pushback from like the payer system yet, like our insurance companies, things like that, with regards to implementing this technology, or has that not been discussed yet? And if you have, you guys think like the big idea of how that conversation is going to go with them, especially as it relates to things like automation of some of our tasks and things like that.
Yeah.
Not being agreed that this remains in sort of the same payer system.
Yeah, thanks for that question. So to summarize for those on Zoom, the question was around sort of payment models and what is the reimbursement model for some of these technologies? Some of the technologies that I talked about, particularly those that have to do with sort of clinical decision support or diagnostic decision support, like retinopathy screening, for example, using the AI fundus cameras, they have associated CPT codes that can be built in the fee-for-service world. But I think that the vast majority of these technologies, and particularly the ones that we care about as primary care physicians, are really going to be implemented in a value-based care setting. And it's all about preventing that unnecessary utilization. And so the value proposition there is downstream savings of dollars, total cost of care reduction. Those are going to be those are the kind of conversations we're going to have with insurance companies. Insurance companies, of course, are using their own predictive models to do some not so great stuff. Read the recent Wall Street Journal if you can about Medicare and insurance companies doing that. So it's going to be really interesting over the next 5 to 10 years to see how these reimbursement models evolve the technology. Yes.
So obviously there's a lot of incredible benefits from AI and machine learning, but because it's something so new, there's still so many questions. And you showed that diagram of all the different code of conducts going around. Just recently, we've had lots of events with CEOs of some of these AI companies on Capitol Hill being grilled by policymakers. Do you see the immediate threat that could inhibit some of these things that you and others are going through?
The question, if I understand it correctly, for those on Zoom, is sort of threats to ongoing work around creating codes of conduct and responsible use governance mechanisms around AI. I would say that the immediate threat is that everything's moving too slowly. And it's not matched the pace of technology development, right? So I'm worried that by the time we create that code of conduct in 3 years, AI will be so far ahead of what we can even imagine today that the code of conduct might be irrelevant or need to be reworked significantly. It feels like we're always trying to catch up from a regulatory standpoint. So unfortunately, a lot of it depends on self-governance right now, technology companies, whether we like it or not. So that's another reason why I believe direct engagement is really important with the technology developers that are in the thick of doing this stuff. So they have a profit-driven motive, but we have to make sure that we push back with an equally important primary care perspective, as well as getting them to really understand the unintended consequences of their work, the ethical and equitable implications of their work. And, you know, I'm actually a little bit more optimistic than I think some people are in this area, because I work directly with a lot of these companies, and they're not evil people. They're, you know, good, well-intentioned people that have blind spots. And so by having conversations, by having that kind of dialogue, it gives me hope. Like, I feel like, for example, in the derm assist project that I mentioned earlier, that our team was able to move the aircraft carrier that is Google just a little bit towards thinking about community as an important place to develop their products and to listen to the community when it comes to co-development of their products. So I'm a little bit more optimistic than some, but there are definitely threats.
So, I just want to take a minute to say, so aside from the AI, very important leadership lesson within this. I think it's very important when you're doing the strategic planning and you're planning your project out, the idea of spending a lot of time thinking about what you can actually execute, right? Putting that into the strategic process and in the planning process is very important. And it's missing, I think, really from a lot of projects that I've seen. So I think that's really a great strength of a lot of the programs that you're putting in, if you don't mind the editorial comment.
Thank you.
So this is from the department. As a visiting professor, we got you a little bit of a plaque. So
Thank you very
and
much.
just without breaking it. Right? There we go. I don't know what am I doing?
Hard to get it out of this thing.
Oh no, there we go. Okay, so anyway, so it talks about the kind of professor you are, and it's just a commemoration from us.
Oh, thank
to
you very much.
So thank you very much for
appreciate
coming to
it.
be our
Thank
visiting
you.
professor. Very thoughtful to have. And then this is from the department, right? I mean, from the residency, right? So you ever in the military? So if you're in the military and you're in a unit, they have a unit coin, right? So it kind of marks you as part of the unit. So everybody in the unit
Wow.
will get a coin. So we brought this tradition from the military. So this marks you as part of our unit. This is the highly sought after, seldom presented, but always treasured family and community medicine challenge coin. It's a little bit less than a plaque, but it's a little more than a handshake.
Thank you very much. I really appreciate it. Wow. This is awesome. And I just want you to know that I'm always available. So my email's there. If you're interested in looking at our website, you can scan that QR code, but happy to answer questions, happy to collaborate. And, you know, if you get nothing out of this, I want you to hopefully just leave away with this thing, which is, I don't think you need additional AI or ML expertise or training to do meaningful work in this space. I think all of you have exactly what you need, which is how to be a really good family physician, understand health systems. And if you want to do this kind of work, you can, because I don't know anything about AI, and it's a lot of fun. And I think it's going to be really important work. Thank you so much.
Thank you.